back it up with your physical exam, and then from there, look at the labs and the imaging to kind of dictate what you think is going on with the patient. And so the history should give you most of what you think is going on, or give you a good idea or a good roadmap. And so that's why we spend most of the time on the history in general. Again, you have less information for this case, so I don't expect you to know everything. What I want you to do is try to think as logically as you can about the case. Think with that process in mind. And so if you need help, it's okay to tell me that you don't know. I realize that this is going to be a lot harder for a lot of you, and that's okay. All right, so with that, let's get started. So Dr. Saji's up first. So we have a 56-year-old male with a 30-pack year smoking history and hypertension, presents to the ER with worsening abdominal pain for the last 2 weeks, located in the upper abdomen, and it feels kind of like a pressure type pain. So with his history, what's important to think about with that? All right, let's go with Dr. Tovar. What is important about that history?
I would say his smoking pattern pretty high.
Yeah, so he smoked a lot. So what does that put you at risk for?
Lung problems.
Yeah, so lung problems. What are you most worried about in the lungs?
Cancer?
Yeah, so cancer. So patients that smoke a lot have a high risk of lung cancer, and that lung cancer can be deadly, right? So that's why we're typically more worried about smoking and how it affects your lungs. So if it causes cancer in the lungs, is it possible to cause cancer in other places as well?
I'm sorry, can you repeat the question?
Yeah, so if it's possible to cause lung cancer, if smoking can cause lung cancer, is it possible for it to cause cancer in other parts of the body as well?
I would think so, especially because of his complaints, his chief complaint.
Yeah, so he can have cancer in other parts of the body, and smoking can be a cause of it. It's not 100%, but it's something that we want to keep in the back of our mind. All right, good. And what else can smoking do?
Other than the lungs?
Yeah.
I guess the immune system would be less than optimal, especially because of his really long history.
Maybe. What about so smoking can cause an increased risk in heart attacks. Why?
Because the blood wouldn't be circulating properly.
Yeah, so it causes some narrowing of the vessels in the heart, right? So if it narrows the vessels in the heart, or it contributes to that process, it can cause a narrowing of vessels in other parts of the body as well. And so so definitely lung it's not just lung cancer, it's not just COPD. It can cause other issues as well, and the big one that we see a lot are circulatory problems, whether that be in the heart or in other parts of the body. It can cause decreased circulation, decreased perfusion because of the narrowing of the vessels. So good. All right, and so I say the pain is located in the upper abdomen. So when we think about upper abdominal pain, what are you thinking of?
I would think of the appendix and the spleen or the stomach.
So the appendix is a little lower, but the spleen and the stomach definitely. Anything else in that area? The same area as the spleen and the stomach?
The gallbladder?
The gallbladder, good. What's next to the gallbladder? Or what's the gallbladder under?
The liver?
The liver, good. What's next to the stomach, or a little bit below the stomach?
the pancreas and the kidneys.
Yeah, the pancreas, and then behind in the back are your kidneys. Also back there, you can also have like aortic problems as well. So like an aortic dissection can be going on there too. So yeah, good job. All right. So he's been having difficulty eating. He's getting full easily. He's lost 20 pounds in the last month. So Dr. Faruqi, what is concerning about that statement?
So if he's not intentionally losing weight, he's losing, and he's getting full easily, it could mean that maybe like there's like a mass in like his stomach and that's like taking up space. And so then he can't fit as like much food inside of his stomach. And so that could cause him to be full more easily.
Yes. So the stomach is basically just a sac, right? And so there's a certain volume of the stomach that it can expand a little, can stretch a bit, but as it stretches, you start to feel more full. And so if in this sac you have this mass kind of taking up a bunch of volume, now you have less volume to put food in. And a lot of patients, if there is something in the stomach like that, they'll feel full pretty easily. Same thing with like gastroparesis, where you're not able to push that food out as quickly, and because the nerve signaling is a bit messed up, and so you're not able to push the food out, which causes more volume to be retained in the stomach at any given point. So when somebody wants to eat, they eat a little bit and they already feel full. So so definitely it can be because of something in the stomach that's not letting him eat. And then you mentioned intentional versus unintentional. So if it's an intentional weight loss, like you're trying to lose weight, good for you. You lost 20 pounds, you're doing really well. But if it's unintentional, then you have to think about some of the more serious complications. So what are some of those more serious things with unintentional weight loss?
So if he's not intentionally trying to lose weight, that means that he could possibly have like a lack of nutrients inside of his body because he's not able to eat as much as he needs. And maybe there would be, well, yeah, and that could also explain his like fatigue as well, because if he's not gaining enough nutrients from the food that he eats, then he could also be fatigued because of that.
Yeah, definitely. If he's eating less, he's not getting those nutrients in, he is still working as a construction worker, that can definitely cause that can definitely be concerning. So good. So Dr. Stephanie, you're mentioning cancer. Why would cancer cause you to lose weight?
Cancer, you guys could hear me, right?
Yeah.
Cancer essentially does everything in its power to take away from the body so it could survive. So it will use up more of the energy he's eating, so it could be produced at a higher rate, so it could increase its likeliness of increasing cell.
Yeah. So basically, with cancer, so cancer in general is just an abnormal growth of cells. Those cells are growing rapidly and dividing rapidly, and every time a cell divides, it requires a lot of energy. And so if that cancer is growing out of control and it's requiring a lot of energy to grow like that, then you start to have divert those nutrients from the rest of your body to that cancer itself. And so what ends up happening is the overall nutritional status of that person is all being diverted to that cancer. So they are not able to maintain that nutrition. So what will end up happening is that their own body will start to break down some of the fats and other nutrients to compensate for it, and you will, and that's why they start to lose weight. So yeah, you're exactly right. That cancer, because it's that abnormal growth of cells, and because it requires a lot of energy to grow and divide, you're diverting nutrients to somewhere where it's not supposed to be. So good job. All right. So he also says that he denies any difficulty swallowing food or water. So, Dr. Kamara, why is that important to know?
I feel like you guys can hear me, right?
Yeah.
Okay, I feel like that just shows us that if it's something related to his GI tract, it's probably lower down and not in his mouth or in his throat.
Yeah.
So maybe related to his stomach or just something lower down.
Yeah, and so why are you saying that it's not the esophagus? Like, so can you walk me through your thought process there?
I feel like if it was something related to his esophagus, he would have more difficulty swallowing and he would feel more pain in that area. And that is something he would probably tell us during the consult.
Yeah, so when people have a difficulty swallowing because something's getting stuck in their esophagus, sometimes they feel like they're choking. Other times they feel like there's a mass in their throat that they can't get rid of, and it's really uncomfortable and can cause a lot of discomfort and pain. And so the way that the esophagus works is you swallow the food or the water, and the part above where the food is. So, like, let's say this is your food right here. The part above, the esophagus part above, is going to contract to push that forward, and then it'll contract, push it forward, and it'll go down. So the ways that you have like an esophageal obstruction, or if you have a difficulty swallowing, is because one, the nerves might not be working, so that contraction mechanism isn't coordinated, and so you can have spasms throughout the esophagus that are uncoordinated, and it causes that food not to move. The second is if there's an obstruction, like a physical obstruction, so something like a mass or a cancer, where it squeezes up top to push it down, but there's a physical barrier there because that cancer is growing there, so that food can't get past it, and it feels like there is something in that throat. And so the fact that he doesn't have any difficulty swallowing is really important because it tells us, maybe it's not the esophagus. So this all goes to narrowing down where this issue is originating from. So good job. All right, so the patient is saying that what's most bothersome is his fatigue. He's not able to keep up with his daily routine, and he works as a construction worker and now has to rest about every hour. So, Dr. Torres, why is that important to know? Is she muted? Okay. So, Dr. Baltasi, why is that important to know?
Hi, can you hear me?
Yeah, we can hear you.
Can you repeat the question? Sorry.
Yeah. So he's complaining that what's most bothersome for him is that he can't. He's very fatigued and it's getting worse. He's not able to keep up with his daily routine, and he works as a construction worker, so it's becoming more and more difficult to do it because he has to rest about every hour. So why is that important?
Well, it's important because, it has been affecting his daily routine pretty heavily. And because he's a construction worker, he's supposed to, be used to enduring that level of work.
Yeah, so he's a construction worker. He's used to hard labor, and so not even being able to do his daily routine because he's so tired is pretty significant. So that's a pretty significant change in his baseline. So he's also admitting to some pretty severe dizziness. So every time he gets up quickly, he gets really dizzy, and it takes a while for him to get better. What are your thoughts about that?
Well, as I was reading the case, I saw he's taking some medication for hypertension, and the side effect of lisinopril is dizziness and fatigue, so maybe it can be related to his medication. I'm not sure how the dosage that he's taking, but maybe that.
Yeah, good. So if how would his lisinopril cause him to be dizzy? What's that mechanism?
I'm not really sure of the mechanism, but since it's related to blood pressure, maybe when he gets up too fast and it's related to blood pressure, since when you get up, because of the gravity, the blood is pulled down, maybe it's because it's related to that. I'm not really sure about the mechanism behind it, though.
Yeah, so it's not super complicated. It's actually pretty straightforward. So any blood pressure medication can cause you to be dizzy. It can cause you to feel fatigued because what does blood pressure medication do?
Well, it lowers.
It lowers your blood pressure, right? So if it lowers your blood pressure, if you take too much of it, what is it going to do?
Well, it will mess with the body function, right? So called dizziness and I'm not sure.
Yeah, so it's you're not sure because it's obvious when I'm asking. And it's going to lower your blood pressure too much, right? You take too much medication, it's going to lower it too much, and so it's all you're definitely right. It's always important to look at the medications because you want to make sure that the medications are not what's causing him to be symptomatic, so fatigued or dizzy in this case. Good. So all of us get up quickly, and all of us have, or most of us have felt lightheaded. I don't know, have you felt that before? Like you get up too quickly and you feel a little lightheaded and it goes away?
Sorry, I'm muted, I think.
It's okay.
Yes.
Yeah, okay. So why does that happen?
Well, I think when you get up fast, when you get up, the blood pulls down.
Okay.
I believe due to gravity. So I think it's related to the blood volume.
Okay.
Heart and the pressure goes up, maybe, I think.
Yeah, so it's the blood volume, right? So you get up too fast, gravity starts working on you, and your blood goes down to your legs. So good job. Dr. Annabelle, after your blood pressure, after your blood return goes down, the volume going back to your heart goes down. Why does that cause you to be dizzy? We can't hear you. Or at least I can't.
I can't hear you now. I don't think I can hear you now. Sorry. Okay, sorry, I can't hear you, but I'm gonna try to answer the question. Sorry. Isn't it because the blood doesn't go up to your head because it just, well, wouldn't it be like something like orthostatic hypotension? Isn't that like a condition? Okay, thanks, sorry. And then isn't that like just due to like basically just gravity? When you get up, it decreases your blood pressure. So then you're like, oh, I think I hear you now.
Okay, good.
Okay, sorry about that.
No, it's okay. It's okay.
And then you need like a certain amount of blood in your brain. So if it's going down like that, you're gonna get dizzy and lightheaded.
Yeah. So your body is gonna want to maintain a certain level of perfusion, right? So your cardiac output is what we're looking at. So your cardiac output is basically what your heart pushes out as it beats. It's a function of the stroke volume and the heart rate. So cardiac output equals stroke volume times heart rate. So the stroke volume is how much your heart, how much volume is pushed out every time your heart contracts, and it pushes that blood out to the rest of the body. And so if you have less volume in your body, so that volume goes down because you're not allowing for as much blood to come up to the heart because it goes down to your legs. What is your body going to do to compensate, to maintain that cardiac output?
Wouldn't it try to pump more blood?
And how does it do that?
By making your heart rate faster, I guess?
Exactly. Yeah,
Okay.
exactly. So you make your heart rate faster, and because as you make it faster, you're trying to push out more volume, right? So it's going to have more contractions per minute. And so with that, if you yourself stand up and you palpate your pulse, like you palpate your pulse, you stand up, you walk around a little bit, you will feel your heart rate go up just a bit, and your body's able to compensate for that decrease in return, because you have a good amount of volume on you. If your volume down, if you're really dehydrated or you're bleeding or something like that, and even with that elevated heart rate, you might not be able to compensate, and you're going to feel dizzy. You're going to feel like you're going to pass out. And so, so that's generally how it works. Does that make sense?
Yes.
Yeah. Sorry, I didn't know what happened there. That was actually really funny.
No, sorry.
Okay. Cool. All right. So, where were we? All right. So we talked about the dizziness. So, Dr. Borja, the patient has been complaining of back pain for the last 2 months. More notable in the left mid back, and it's a deep ache. Nothing is making it better. So what are you thinking about there?
Okay, I hope you can hear me because my connection is kind of sketchy.
We can.
Okay, but I think someone just commented, but I was thinking about like the kidneys, because someone mentioned that there could be a mass in the stomach, right?
So there might be a mass in the stomach, but when we're talking about, so the patient is saying they're having back pain kind of like right here in this area on the left side. This is my right side, but they're on the left side. So with that pain there, so what's in that area? What would you be thinking of, like organs wise?
Well, like I said, I thought of the kidneys first, but like just because at least for me, from like maybe it's just personal experience, my godmother actually had a mass in her stomach that ended up metastasizing to her kidneys. Okay. So that was why that's why I thought maybe it to the kidneys.
Yeah, for sure. Like definitely the kidneys, that having a mass in that area can definitely cause pain. What else could be going on with the kidneys that can cause pain in that area?
Kidney stones, maybe.
Kidney stones. What else?
I'm not sure.
That's okay. So we have stones. We have a mass. What about if they have a fever? If they're having pain when they urinate? They have a little blood in there. What would you be thinking of?
An infection.
An infection. Yeah, UTI, or specifically, if it goes up to the kidney, it's going to be pyelonephritis, right? So it's going to be infection of the kidney itself. So good. So you have all these different possibilities in the kidney. So we know maybe kidney problem. What else is in that area that can cause pain?
Okay, I know the adrenal glands are over the kidneys.
Yeah.
Around there, liver, pancreas. I feel like I'm too far forward.
It's gonna be more on the right side. What about just kind of go from the skin downwards? What are you hitting? So skin, if you had some type of cut or you had like a rash or something like varicella or shingles, that can be painful. Going deeper, what's after the skin?
Just muscles.
Yeah, muscles, bones, right? You have your ribs there. You have your spine in that area.
Okay.
It can be musculoskeletal, right? What if I told you that the patient had like a tearing type pain? So it was belly pain, but it was like tearing, and it felt like it was in the back. What would you be thinking of? What was that? I think you're cutting out. I didn't quite get what you said.
Like the aortic dissection
Yeah.
felt.
Yeah, so an aortic dissection, right? So the aorta is kind of right at the spinal column. It's just right there, and so if you're dissecting that aorta, it can cause that tearing type pain. So definitely, someone on YouTube is saying the spleen. It's in that area as well, so that can be an issue as well. So good job. All right, and so he also tells you that he had blood in his urine that he attributed to a UTI because he had similar symptoms in the past. And so he was treating it by himself with some cranberry juice. So Dr. Cho, if he's having blood in his urine, what do you think can be causing that? And what do you want to get to check to see if there actually is blood?
If there's blood in his urine, then there's something definitely bleeding in that tract. I think UTI could be a cause.
You think what? Sorry?
UTI can definitely be a cause.
Where would the blood typically originate from if it was a UTI?
Is it the bladder?
Yeah, the bladder. So the bladder is going to be inflamed. It's going to be tender. If you do you push on the suprapubic area, you can have some tenderness there. So yeah, if it's the bladder, definitely UTI. So yeah, keep going. Sorry, I cut you off.
Yeah, so he's having like pain in his kidney areas. So definitely it could be the kidney that's bleeding too, that's causing the blood in the urine.
Okay.
And then for blood, you can do like a urine test.
Yeah, so you get a urine sample, you check to see, you can do a dipstick where you kind of just dip that piece of paper in and check the colors and see what's there, or you can get a formal UA, and we'll go over that in a little bit too. So good. And then we'll stick with you. He's saying that he has stools over the last week that are dark and sticky. What does that tell you?
Because it's dark, I think that there might be blood mixing with the stool. So there's also some type of bleeding in the GI tract.
Yeah, so if he has dark, sticky stools, what causes the stools to be dark and sticky?
Is it like old blood that's from like maybe from like the stomach or the
How does
small?
that, if it's from the stomach, why does it become dark?
I'm not sure.
Okay, so that's okay. So when you have, what's in the stomach that's not anywhere else in the GI tract?
Is it the acid?
Acid, right? So when blood mixes with the acid, do you think blood is exposed to acid all the time?
No.
No, right? So there's no real exposure to acid for the blood, and so that's something that's abnormal for it. A lot of times it's going to cause destruction of the blood, right? So as that blood breaks down, you start to release its contents. It's the contents of the blood, the red blood cells start to oxidize, and you get this like darkish color. If you vomit that blood instead of it going down the other way, what does it look like?
Would it be dark?
It'll be dark. There's a specific description of it. Do you know what that is? It's okay if you don't.
Someone in the chat said coffee grounds.
Yeah, it looks like coffee grounds. It looks like seedy, like coffee grounds. And so if it comes up, it looks like coffee grounds. If it goes down, it mixes with your stool. It becomes tarry, sticky, and it's called melena. So yeah. So good job. So this dark, sticky, tarry type stool might be blood. So good. All right. So Dr. Phillip. The patient denies fevers, chills, night sweats, vomiting, bright red blood in the stool, constipation, diarrhea, reflux symptoms, chest pain, and shortness of breath. What is most important in there?
Hello, can you hear me?
Yep.
Okay, so I would think the fevers and chills, and then also the red blood in his stool.
Okay, so why fevers and chills? What does that tell you?
I would think like fevers and fever is a way of like the body fighting off an infection. So,
Okay.
yeah,
Okay, and then what about the bright red blood? What does that tell you?
because it's bright red, like it might not be coming from like the lower part of his bowel.
So if it is bright red, blood, what would you're saying that it would be more from the lower GI tract?
Yeah, because then it wouldn't have the blood would have more time to oxidize, so it probably wouldn't be the lower bowel.
Yeah. So that the dark stool usually happens when you mix with some type of acid, right? So in the lower GI tract, there should not be any acid there, so you're not going to have that mixing and that degradation of the red blood cells. So if you have a bright red blood in coming out of the rectum, a lot of times that is because you have a bleed that's really close to the rectum and where the poop comes out, right? And so that fresh blood that's coming out is going to be very distal. Unless you have a very brisk and fast bleed from like the small bowels, that can traverse very quickly down all of your small bowels into your colon, and basically you're going to be pooping bright red blood, but it's just a very quick bleed, and that can be very dangerous. If you do like a colonoscopy, you don't see anything, but you just see a bunch of blood but no lesions, it might be in the small bowel, and that can be an indication for like a surgery to see if they can stop that bleed. Because if you're bleeding that much and it's not really mixing with the stool that's in there, then you're probably really anemic and volume down. So good. All right, and then we talked about the lisinopril hydrochlorothiazide. So Dr. Phillip, is there anything else in the history that you want to talk about?
Mainly just the smoking is important, and then the lisinopril is a blood pressure medication. So like we could also look at his blood pressure.
Yeah. So the blood pressure, if you took too much of it, of the medications, it definitely decreased. Then the smoking history, he's definitely at risk of all the different complications of smoking. So good job. All right, so Dr. Salim, I'm going to give you the vitals. You interpret them for me. So the blood pressure is 110/66, heart rate is 110, respiratory rate is 16, temp is 99, and O2 sat is 96 on room air. So what's significant there?
Hello. When I looked at the vitals, I thought for someone with hypertension, the blood pressure seemed quite stable. Same with the heart rate. It was a bit elevated, but not too much to cause like risk. With the temperature as well, it was I don't know how it is in America, but I converted it to Celsius, and it was normal temp. So I didn't really find anything with the vitals that stuck out.
So yeah. So 99 here is in the normal range. So yeah, you're definitely right. The temp isn't super elevated. But what if I told you that he's been taking Tylenol for the pain and he felt a little warm at home? Is that something that you're going to be concerned about? Or is it paracetamol over in Europe?
Not that I wouldn't be too worried about it.
Okay.
If it was slightly elevated, but
if so what does that medication do?
Paracetamol. Doesn't it bind to the pain receptors and helps mask the pain for the patient?
It does. But what does it do for fevers? Why do we use it in patients that have fevers?
Oh, does it bring the fever down?
Yeah. So if somebody had a fever, so if they were feeling warm at home, but they didn't have a chance to check their temperature at home, but they're taking Tylenol, paracetamol at home because of the pain. If they come in with a temp of 99 and they have, let's say, a white blood cell count that's elevated,
Yeah.
Are you going to be thinking about an infection at that time?
Yeah, I would be thinking of an infection, raising a bit of a red flag.
Exactly, right? So it has to be taken in context, but you're definitely right that temp is normal. No history of fevers at home. He denied fevers initially, so I probably wouldn't be too worried about that. The heart rate of 110, it is on the higher side. Why is it that heart rate of 110? Why is it significant? What is it telling us?
It's telling us that he's tachycardic.
So
and it's higher than the normal range for his age.
Yeah. So what is a reason why he'd be tachycardic?
Some patients get nervous when they're in a hospital setting. So it could be anxiety.
Okay. So what if we say he's cool, calm, collected, not nervous at all? What else can be causing that?
Be thinking of possibly the heart, issues with the heart, because it's working at a harder pace.
Yeah, it's working a lot harder than it's supposed to, right? So if it's working harder, why do you think it's working harder?
It's pumping more blood, so there must be maybe a possible bleed. So it's working harder to overcorrect the issue.
Yeah. You want to maintain that perfusion, right? You want to maintain that ability to get blood to the rest of your body. Good. And then lastly, the blood pressure you said was normal, right? Is there any reason why I would say that it might not be normal for this patient?
It's because is he taking medication to control his blood pressure?
So what do I want to know about his blood pressure to say that this is definitely normal or not normal?
I'm not too sure about that.
It's okay. So if he's taking blood pressure medication, one thing that we want to know is how well controlled is he? Is he taking blood pressure meds and his BP is stellar? It's like 110 to 120 all the time. Then great, this is consistent with it, right? Versus, let's say he doesn't take it, he takes it like every once in a while, or he does take it, but it's not controlled, and his blood pressure is usually ranging 140 to 150 systolic. So if that's the case, then this is low for the patient. And so we're going to be more worried about hypovolemia. We're going to be worried about him not having enough volume in his body to perfuse the rest of his organs. That might be because of a bleed versus, dehydration versus, other things. So good. What time is it around where you're at, if you don't mind?
It's 8 o'clock in the afternoon, in the evening.
Okay. We appreciate you being here with us. That's awesome.
Thank you.
All right, so good. Okay, so Dr. Ismail, what do you want to get in the physical exam?
I think that one thing I would want to get in the physical exam would be a blood count. That's something that I would want to look at.
So yes, we'll eventually want to get to that. But when you go in and observe the patient, do the examination, what is it that you want to check?
I would want to check if there is a problem in their organs, especially the kidney that you might be suspecting.
Yeah, so what exam are you going to want to do? So you want to check the heart, the lungs, what do you want to check?
So I would want to check the heart and the lungs to rule out if there might be any issues in there.
Okay, and then if you're worried about the kidney in the belly, you're going to want to do
possibly an MRI.
All right, it's I mean more like the examination. So it's probably like an abdominal exam, and it's a lot of you telling me what I'm thinking. So sorry about that. So yeah, let's go through some of those. So the cardiovascular exam is tachycardic. His cap refill is 3 seconds. So we know he's tachycardic. His heart rate's high. Cap refill being 3 seconds. Is that normal?
I think that might be a little delayed.
It's a little delayed. Yeah. So for some people that can be around normal. For young healthy patients, I would typically want to see less than 2 seconds. So what cap refill is, if anybody's wondering, is we basically pinch the finger or the toe and until it gets white, and then we let go and we see how quickly the color comes back, how quickly the redness comes back. And so if there's no issues, it should be less than 2 seconds. If there is a delay because there's less volume, or a delay because there could be a delay because there's less volume, there could be a delay because the supply to that area is low because of like stenosis or narrowing of those vessels, stuff like that. So his is a little bit delayed. We kind of know that he might be volume down because he's tachycardic. So good. The respiratory exam is clear to auscultation bilaterally, so we know that his lungs are pretty clear. So good. Dr. Safe. For the abdominal exam. He has tenderness to palpation in the epigastric region, no rebound or guarding, bowel sounds in all 4 quadrants, no suprapubic tenderness. And so what do you think is important in his abdominal exam?
Wait, can you say that last part one more time? I'm so sorry.
So tenderness in the epigastric region, no rebound or guarding, bowel sounds in all 4 quadrants, and no suprapubic tenderness. So what's important in that exam?
Okay, so we know that since he doesn't have any problems with his. I'm sorry. I'm so sorry. Wait 1 sec. Okay. I kind of have my notes out. Okay, wait.
So we had mentioned in the epigastric region, we kind of talked about it already. That part is tender. So the upper abdomen part is tender. So what are some of the organs that you're thinking about in there?
Oh, your stomach, your pancreas, your I guess you can say kidneys, but they're kind of in the back.
Okay.
Your liver as well.
Okay. Okay.
And your gallbladder. There's no tenderness to your gallbladder, so that's fine. That doesn't mean it's swollen or anything. Right?
Okay, good. So there's a specific exam for the gallbladder that I actually forgot to mention in here. Do you know what that exam is? What it's called?
I can tell you what you do or what you look for. I mean, if it's like swollen or anything, so like you wouldn't want to play like contact sports or anything because it could like explode and it could rupture or something if it gets too big. You check. Okay, I'm sorry. Oh, okay. I think you have to. Okay, never mind. You could just
It's okay.
I'm really nervous.
So it's okay. Don't be nervous. So the exam for the gallbladder is, you might not be able to see it, but you push kind of like right underneath the rib cage on that right side, because that's where the gallbladder is. And so you tell them to take a deep breath in. They breathe in. You keep pushing inwards, and so you're trying to hit that gallbladder as you push in. And so as they take a deep breath in, you're allowing to push more and more into that area. So if they have inflammation of the gallbladder, they'll be in a lot of pain. And so the sign is Murphy's sign. So Murphy's sign is as you push in, as they inhale, they abruptly stop because it's super painful. So they'll go and just stop like that. That's a sign of gallbladder inflammation. I didn't mention it in here, so that probably tells you that it's not as important. So it's not the gallbladder. But yeah, so you're right. So that epigastric region, you hit pretty much all of them. You got the stomach, the pancreas, you have a little bit of the liver, you can have the spleen there. Like you said, the kidneys are in the back. If you wanted to do a kidney exam, what are you going to do?
Well, you want to check for kidney stones, I guess, and if he had like problems like peeing, or I guess, and then
So do you know the exam that you would potentially do when you check the back? What is that called?
You would. I'm sorry.
It's okay. So you would check CVA tenderness. So we're here to learn. So don't feel bad about it. So you would put your hand on the back where the kidneys are, where the ribs are overlying the kidneys, and you would literally just tap, and you would tap pretty hard. If there's inflammation of the kidney, if there is something going on with the kidney, that person will jump up. They will hate you for tapping on their back. They will try to swat your hand away because it's so painful. And so that's called CVA tenderness, and CVA stands for costovertebral angle. So it's that area. Now, this patient had some CVA tenderness, but they weren't jumping up like that. So, it can be the muscles, it can still be the kidneys, it can be the bones, but it's not that acute inflammation that we would typically see. Good. Good. So good job. Dr. Roman, with the abdominal exam, I say no rebound or guarding. What does that mean?
Can you hear me?
Yeah, we can hear you.
I'm not really sure. I tried looking it up. Is that no rebound or guarding is a good thing, I think.
Yeah, it's a good thing.
The muscles weren't tensing back up when they were being pushed on, is what I got when I looked up.
Yeah. So that's guarding. So guarding is when you have so there's two different types. There's a voluntary guarding and an involuntary guarding. So voluntary guarding is like you have a lot of pain in your belly. You're wanting to protect your belly, so your muscles are going to contract and try to protect that area because you don't want to feel pain. And that tells you that there's something going on. It might not be as severe as when you have involuntary guarding, where there's so much inflammation in the area that those muscles are contracting involuntarily. And so as you push down, you'll feel kind of a rigid abdomen. You'll feel like you can't really feel the organs around because all those muscles are tense and contracted. That's a bad sign. That tells us that there's something really serious going on, and you're going to want to maybe get a surgical consult and do some imaging to see maybe what's going on and potentially do surgery. Now, rebound tells us if there's any peritoneal type signs. Involuntary guarding tells us about peritoneal signs as well. So does rebound. So what do I mean by peritoneal signs? So the abdomen, all of the organs in the abdomen are kind of lined with this peritoneum, this lining of tissue and connective tissue that has nerve endings and has lymphatics and all the stuff that help clear the abdomen of anything that's not supposed to be there, but also it lets you know if there's something wrong. So if you have a bleed, if you have like a perforation of the abdomen, you're spilling stool into that cavity, or if you have like an infected acetic fluid, if you have ascites from like cirrhosis and that fluid in your belly is now infected, all of that is going to cause irritation of the peritoneum, and you'll have that tenderness. So rebound is when you push down. As you push down, you're focusing on a certain area, but as soon as you let go, there's a wave of movement in the abdomen, and you can have pain in other places in the abdomen where you didn't push down. So the context of that is that if you push down and it hurts, but if you let go and it hurts more, that's a sign of rebound tenderness. And so, and it's because you have irritation of that peritoneum. And so all of these are signs that there's something more severe going on in the abdomen. So you are right. It's less likely that something bad is happening in the abdomen. Does that make sense?
Yes.
Okay, good. Other than that, his bowel sounds were present in all four quadrants, and there was no suprapubic tenderness. So I think we talked about the suprapubic tenderness, meaning there's probably not a bladder infection. Good. So anything else you want to do for the physical exam?
Maybe a rectal exam.
Good. So how would you do a rectal exam?
I'm not really sure.
So with the rectal exam, you're basically just getting your finger and literally just putting it in the rectum, getting a stool sample out, and a lot of times you'll see bright red blood if there's bright red blood. If there's not, you put it on this little card. You wipe it on these two little boxes on this card, and you put a solution on it. If it turns like a blue color, that tells us that there's a bleed there. There's blood in that stool. And that's important because a lot of times it's hard to see that blood because it's mixed so much into that stool. So for him, he had melena, so he had that dark tarry stool which lit up. Sometimes it's not as obvious. So yeah, we would want to do a rectal exam. So his was positive. So good job. All right. So Dr. Gamara, what labs do you want to get?
Can you guys hear me?
Yep.
Okay. I guess just like the stool sample, like you said.
Okay, we got that, and it was positive for blood. So if it's positive for blood, what are you going to want to check next, as far as blood tests goes?
Like a urine sample. I'm not really sure.
Okay, so yeah, we can check the urine. So it shows a specific gravity of 1.03, and it has positive blood in there as well. Otherwise normal. So what does the specific gravity tell us?
That there is some form of internal bleeding.
So specific gravity refers to more of how concentrated the urine is, right? So is this a normal specific gravity?
No, I don't think so.
It's technically the higher side of normal, but for me, this is really concentrated, and it's probably the patient's probably really dehydrated. So that's one of the signs of dehydration. If you look at the urine and you see a high specific gravity, it can tell you that patient is dehydrated. What about the blood? Is blood in the urine normal?
No.
No. So yeah, you're right. So the only time that it's normal per se to have blood in the urine is if you have a young female and they're on their period, basically. So that blood is mixing in accidentally with that sample, but you would still want to make sure that it clears out afterwards. So it's not normal for it to be coming straight from the urine, but sometimes you have mixing on accident. But yeah, so there's blood, so that's not normal. So why is this not UTI? Because we said that UTI is possibly one of the causes. So why isn't this a UTI?
Because of the CVA tenderness, I think. Like that.
So,
yeah, that was it, and yeah.
So CVA tenderness can be from a UTI that travels up and causes pyelonephritis, but for this urine dip, there is no leukocyte esterase or nitrates, and both of those are signs of a UTI. So leukocyte esterase is one of the byproducts of having white blood cells there, and white blood cells cause inflammation, and they're recruited there because of that infection. And nitrites, I have to look it up again, but I believe it's one of the breakdown products from gram-negative bacteria like E. coli. So both of those are signs of having a UTI. Hers are normal, so it's not likely a UTI. You can always get a culture just to make sure. So good. All right. So Dr. Ash, anything else? What's the next lab that you want to get? Let's go with Dr. Cardani. Any other labs that you want to get?
In addition to, can you hear me?
Mm-hmm.
In addition to the urine dipstick?
Yeah. So yeah, in general, what labs do you want to focus on?
I'd say like maybe get like a CT scan of the area.
So before we go to the CT, what labs do you want to check, like blood exams?
Oh, blood exams. The hemoglobin. So
yeah. So is hemoglobin 7.2? Is that normal?
That's actually low. So
yeah. Is it like okay low? Is it super low?
I think it's super low.
Yeah, it's pretty low. So you see that hemoglobin, you have a guy that's tachycardic, he looks like he's having a bleed from the GI tract. What are you going to want to do?
I'm going to check like with the scope to see if he's bleeding, like, and maybe like where exactly in the upper part of his GI tract.
Yeah, maybe. But before you even do that, is any GI doctor going to want to do a scope with the patient with a hemoglobin 7.2, tachycardic, dizzy, low blood pressure?
No, we're gonna want to stabilize him, so probably IV fluids and a blood transfusion.
Yeah. So we're going to give him some blood. How much blood do you want to give him?
I'm saying probably like a bag. I'm not exactly sure how like the quantity works for hemoglobin.
Yeah, it's okay. I don't expect you to know that. So typically we'll give units of blood, right? So the first unit of blood would increase the hemoglobin by 1 point. So our goal is to be above 8 for anybody that's bleeding. So 1 unit would probably do the trick, but he looks like he's continually bleeding. So they actually gave him 3, but I think that was in the context of the entire hospitalization. So I would probably give him 2 because we know he's going to bleed a bit more. So good job. All right, Dr. Maliha, what other labs do you want to check?
I would do a CT scan.
Before the CT scan, what do you want to check before you get a CT scan?
So we know that after we stabilize him, we want to go in to see if he has internal bleeding. So what do we do? Like look with the scope now?
So not necessarily. So let's say we are going to do a CT scan. So let's go with that. Before we do a CT scan, or actually first, what type of CT scan do you want to get? Do you want to get it with contrast or without contrast?
I would get it with contrast,
Why?
just because we suspect that he might have cancer, and cancer is very vascular. So you want to see like all the veins and see like what obstruction there might be.
Okay, so good. So exactly. So we want to see if that potential cancer lights up because it's so vascular. So you want to get him the CT scan right now?
Yes, but first I want to see if like his hemoglobin and his white blood count has like increased after we have given him the blood.
So let's say he adequately came back with his hemoglobin. His white count stayed the same. Are you good to do the CT scan?
Yes.
Okay. So we do the CT scan, and now he's not peeing anymore. Why is that?
I think it's because we gave him CT scan with contrast. That can also like lead to internal bleeding, and that can if you suspect blood in the urine, then that might like affect that. I'm not exactly sure.
Yeah, so I'm pushing you pretty hard, and I appreciate you sticking with me. But so before we do a CT scan, and especially if we're thinking of do a CT scan with contrast, we always have to get what lab? Do you know?
No, I'm not sure.
Okay, so creatinine. We want to know what the kidney function is first. Why do we want to know the kidney function?
We would want to know kidney function just to see if, because I'm not sure, but in the physical, it said that he drinks 2 to 3 beers, and you want to make sure, like, the kidneys if there's any kidney damage or the kidneys function like working properly. So you want to look at the creatinine level.
So the beers won't necessarily do anything to his kidneys per se. It's because with contrast can be toxic to the kidneys. It can make a acute kidney injury worse. And if you have poor kidney function, you're not able to excrete that contrast as much. It sticks around more. It can be more toxic to the kidney. And so with the creatinine that he has a creatinine of 1.8, and his baseline is 0.7. And so if that's the case, are these normal kidneys?
If his baseline is 0.7, then it's increased?
Yeah. So that means that he has some type of injury, right?
Mm-hmm.
So we wouldn't want to give contrast in this patient because it can make that kidney damage worse. Does that make sense?
Yeah.
Okay. So good. All right, now,
I just have a quick question. Sorry.
Yes, what's up? It's okay.
So if you suspect him of having cancer that possibly might have metastasized, how would a CT without contrast look like versus a CT with contrast?
So the CT without contrast will, you can still see some type of delineation between the mass and the regular tissue. It's not going to be super consistent, but what happens is that the mass is going to grow abnormally, and so you can have a like normal lining that you would typically expect, and you'll see that kind of like a bump, or you'll see something irregular in that area, and so so when that happens, and you see kind of that irregularity, you can assume that that is abnormal tissue there. And so I can see if I get you some examples of what a mass would look like with and without contrast. But with contrast, what you would see is the mass itself looks more bright, because that contrast looks white when you give it. And so you see that the contrast between the actual mass itself, because there's more of the contrast that you put in the veins in that mass versus the other tissues around it. So that's what I mean by it lights up. You see it more brightly. Does that make sense?
Yeah, that helps. Thank you.
Okay, good. And so that's why it's important, but we can't give it if that patient has a kidney injury. And honestly, a lot of times patients come in with kidney injuries, so it's a little frustrating. But typically all they need is a little hydration, and in this case, some blood, and it gets better. But good. All right, so Dr. Arun, the BUN is 40. Why is that important?
Can you hear me?
Yeah.
Okay. So, 1 minute, sorry.
Mm-hmm.
I believe that what I was reading, that it was too high.
Okay.
And the creatinine was also too high.
Okay.
Which could indicate a problem with the kidneys.
Yeah. So definitely there's some type of kidney issue going on. The BUN, it can also indicate there's a kidney injury as well. So with the creatinine and with the BUN being elevated, we know maybe there's a kidney issue. But is there any reason why the BUN is also helpful for other things?
I'm not sure. Sorry.
It's okay. It's okay. So it's a harder question. So the BUN, like Dr. Baltasi is saying, that it can indicate a GI bleed. And the reason why is because BUN is blood urea nitrogen. It's a breakdown product that you find in blood. And so as you're breaking it down in the GI tract, part of that BUN can be reabsorbed into the body, and that causes an elevation that is higher than the elevation that we typically will see in the creatinine. And so if the ratio of BUN to creatinine is higher than we expect, it can tell us that there is a potential GI bleed, because you're reabsorbing more of that urea nitrogen. And so if the BUN is 20 times higher than the creatinine, that can be an indicator of a GI bleed. And in this patient, it was a little bit more than 20 to 1. So yeah. Good. Dr. Stephanie, what's your question?
Yes. So if we're concerned of GI bleeding, would we not do the CT scan automatically just to make sure the patient doesn't bleed out? Wouldn't we do like echo to make sure, to check where it's bleeding, to see if we need to call a surgeon?
Yeah, so that's a good point. It all depends on how stable that patient is. So by the time the patient's going to be in the ER, you're going to go and assess him. You're going to see that he's tachycardic, his blood pressure is low, he has signs of bleeding from the rectum, but he's sitting there comfortably and is able to talk to you. So sorry, one second. So I know we're a bit over time, so if anybody has to leave, that's okay. You can go ahead and go. Don't feel bad about it. We are over. So you can always just come back and watch the rest of the stream when you're done. So All right. So if he looks stable, you give him blood and he looks okay, then that's fine. You don't necessarily have to go straight to a calling a surgeon or doing something like an endoscopy to try to stop it. You can do that CT scan, especially if you think that there's other things going on. So in this patient with the blood in the urine as well, I think it would be reasonable to try to do that CT scan first to see if you see anything that is there, to know what you're dealing with, so you're not just blindly going in doing a scope or and not really getting what the actual lesion is. So does that make sense?
Yes.
Okay, good. All right. So I think we got most of it. So Dr. Rachel, can you give me a summary of the case and what you think is going on in this patient?
Is that me?
Yeah, probably. Yeah.
Okay.
Or
So
actually, it's okay. You can give me your summary.
okay. I might have missed it, but did you give the results of the CT?
Not yet. So
Okay.
what do you think is going on in the patient, and what do you want to get next?
So the tests we have are UN and so we have creatinine, UN, and did we look at the urine dipstick?
Yeah. So the urine shows blood. So I guess overall, what do you think? What's your assessment of the patient? What do you think is going on? Like, what's your differential? What's your diagnosis?
I would say that for the most part, the issue is primarily within the kidneys, because looking at all of like just overall, a lot of signs point to like a kidney damage, like a kidney injury, or maybe like a macrocytosis, something like that.
So there's potentially a kidney problem. But what about the GI tract? Why would a kidney problem cause bleeding in the GI tract?
I don't think so.
Yeah, probably not, right? Unless there's some weird communication between the two, but most likely not. So is it possible that there's two different things going on in this patient?
Yeah.
Okay, it's possible. Is it probable?
I mean, we don't have like other indications of like other issues other than like all the kidney problems and the GI bleed. So I want to say no.
Yeah. So the reason why I would say no, and this is just my style and my way of thinking, other doctors might be different, is because these two problems occurred around the same time. And it would be weird if this patient had an acute GI bleed and acute bleed from the urinary tract at that same time. It would be too much of a coincidence, because each of those, I mean, they have their own probabilities and all that, but both of them together, it would be a bit low. So I always try to figure out, is there something that can be causing both? And if you think about it, is there anything that you think of that can cause both of those injuries?
Could cancer be the thing that causes both?
Yeah. So cancer is definitely high on the differential. And so we talked about getting a CT scan. So the CT was limited without contrast, but there was a 3-centimeter mass in the antral portion of the stomach. So that part of the stomach that's heading towards the duodenum. And then there's a 5.5 centimeter irregular solid structure in the superior pole of the kidney. So there's two masses there. If we're thinking about the anatomy, and we're thinking about what's going on, which kidney do you think has the mass, the left or the right?
I would say the left, because that's where the pain was, and then the stomach is also closer to the left side, like, of your body.
Yeah, so definitely the pain helps you out, but if the patient had no pain in that area, it would still be the left side, exactly for what you're saying, because it's closer to the stomach. And so the metastasis is more likely to go towards the stomach because it's closer to the stomach, versus going all the way across the abdomen to hit the stomach. That's a little less likely. So good. All right. So Dr. Chica, what do you want to do next? You have these two masses. Where do you want to do next?
I would probably want to, wait, can you hear me?
Yeah, I can hear you.
Okay. I'd probably want to deal with the one that's bigger, so the one that's in the kidney, before the one that's in the stomach. We could probably take a biopsy also.
Okay, good. So we want a biopsy. Why would you go to the kidney first?
Because it's bigger, so it probably was there before the one that was in the stomach.
Good. So we're thinking about which one is the primary cancer, right? Which one is the one that occurred first? You know, likely the kidney because it was there. It's bigger. But if we're getting a biopsy, which one's going to be easier to get to?
Probably the stomach.
How are you going to get to the stomach?
Through like the mouth, you can use a tube, like an EGD.
Yeah, so you can do an EGD, get that scope down the mouth into the stomach, and look around, see what's there, and then you can also take a biopsy. What's the other advantage of doing an EGD?
I think there was bleeding going on, so the EGD could stop the bleeding from the stomach.
Yeah, you can clot it off, and so you can burn it off wherever that bleeding is. So the EGD showed an ulcerated mass in the antrum of the stomach with notable oozing. A biopsy was taken, it was clotted off, and hemostasis was achieved. So so they took a biopsy, they burned off that area that was oozing, and they saw no more oozing, so they took it out. They sent that biopsy to for pathology. So we admitted the patient for the anemia, for the tachycardia, and the signs and symptoms of the GI bleed. Do you want to wait for that biopsy results to come back before he leaves the hospital, or are you okay to let him go home if he's stable?
If he's stable, then I think it's okay for him to go home rather than waiting there for the biopsy.
Yeah. So a lot of times we're gonna go ahead and send him home, and that's what we did here. We sent him home, and when the biopsy results came back, he was sent to Hemonc. So, okay. So, is there anything else you would want to do? And anybody can answer this. Is there anything else that you would want to do prior to starting treatment for this cancer?
Consult an oncologist.
Okay, so we consulted an oncologist. What is the oncologist going to want to do?
See the biopsy results.
Okay, see the biopsy results. And so the biopsy came back as renal cell carcinoma metastatic to the stomach. So what else do you want to do before you start any treatment?
Order more labs.
Okay, so maybe order some more labs, but what labs would you get?
I honestly don't know.
Yeah, there's not really any other labs that you would potentially get. There are some, but they're not as helpful. But there's something else that you would want to do.
Excuse me?
There was something else that you would want to do other than labs to figure out how you're going to treat this patient.
I'm sorry.
So it's okay. So Dr. Aquila, what else are you going to want to do? Or Dr. Chica, what do you want to do?
Hi. I would check to see if it's spread to anywhere else in the body, the brain, any other important organs.
So how are you going to do that?
Scanning.
Yeah, you can get a scan. You can do a CT scan. This time you're going to do it with contrast or without contrast?
With contrast.
Yeah. So we're gonna see if the kidney's okay, and once the kidney's okay, we're gonna use contrast to see what the extent of the tumor burden is, because that's gonna dictate what type of treatment you can get. As it is, I believe he's already stage 4 because it's already gone to another organ, and so it's gonna, if it's in the brain, you are talking about like chemoradiation as well. And so that's why it's important to kind of know what the full extent is. Someone on YouTube is saying remove the masses. So Dr. Cantor, are you going to be able to remove the masses in this case? If you are, why? And if you're not able to, why not? All right, Dr. Anisha.
Sorry, can you hear me?
Yeah.
Sorry, could you repeat the question again?
So someone on YouTube is saying that we want to remove the masses. They're asking if we can remove the masses. Why would you want to remove the masses, and why would you not want to remove them?
Okay, I don't know too much about the specifics of cancer and how you would handle the masses, but I would guess that removing them would probably, depending on how far they've spread or how big they are, could cause some issues in the organs if you're removing a bunch of tissue from that area. Yeah.
Exactly. So,
Okay.
so that first part is the most important part that you said. So how far they spread. So we have cancer in 2 parts of the body already. So are you going to go and do a surgery for the kidney and then do it for the stomach? But then what if it's somewhere else that you don't know about, right? And now you're going to have to go and do another surgery. So all of these surgeries added up cause pretty significant morbidity and mortality to the patient. And so that patient can be injured from all those surgeries. They all have the risk. So whenever cancer spreads from wherever that first spread was, a lot of times we don't do surgery because it doesn't make sense to do it because we're just exposing that patient to more risk. So what would you want to do instead?
I would, well, first I would want to make sure we know where it has spread specifically before we start doing any surgeries. And I would, I don't know, is there a way to treat this with medication instead of going straight in for surgery?
Yeah, so it would be more chemo is what we're gonna get at. So we wouldn't be able to remove the cancer just because there's too much of it. And we don't know, even if we removed it, there's sometimes like debulking surgeries where you can take out part of the cancer, or if it's impinging on some vital organ, you can take that out so that person has a better quality of life. But for the most part, we won't, and we'll do chemo. And so this patient had a chemotherapy, I believe, with a monoclonal antibody. So it's a medication that's an antibody that's specifically targeted to one of the pathways of this cancer. But he required multiple hospitalizations for the GI bleed and to control the bleeding from the abdominal mass. And so he required multiple transfusions. So he was in and out of the hospital during his treatment. So I have to go back and see what ended up happening with the patient. But I chose this case because it's not straightforward. It shows you that there's a lot that can be going on with the abdomen. There's a lot that can be happening that can cause the abdominal pain. And so it's important to have a system in place where you can go from, the beginning symptoms of what they're talking about, tease out more of the information with the history, and then use that framework to then verify what you're thinking with the physical exam, with the labs and the imaging. You should never really rely on the labs and imaging to give you the answer because in the end, I'm giving you labs, so it's a little bit easier. But with a real patient, you're going to be the one that's going to order the labs. And so if you need to have that structure in place, you need to have that ability to work through the history and figure out what's going on to guide what you want to do. And that's why I say that the history is probably the most important part, and that's why we spend most of the time on the history here. Okay, is there any questions? I know we're pretty over, so if there's any questions, I can stay and answer them because there's nobody after us. But if anybody has to go, that's okay too.
I have another question.
What's
So
up?
if it's spread, doesn't it? We tend to assume that it's already in the lymph nodes, so that's why we don't do surgery to remove it because it could be anywhere else in the body at that point.
Yeah, potentially. It depends on how it spreads. So you can spread through the lymph nodes. You can spread through the blood. You can spread by just having 2 organs touching each other, and and it spreads like that. The lymph nodes is a common way. Blood is also a common way. So yeah, but it's more because it's in another organ already, and it's a pretty big organ. It's a pretty big mass as it is. So Dr. Alexa's asking about radiation. You can do radiation, and it depends on, there's a lot of factors that play into radiation. Radiation can decrease the size of the cancer. So yeah, you can potentially do radiation. You're gonna have to talk to a rat oncologist for that though. So was the stomach fullness due to the mass or the bleed or both? So the stomach fullness was probably because of the mass. You have a 3 centimeter mass in that area. And 3 centimeters isn't really huge, but it can be because it's obstructing that outflow tract of the stomach or making it harder for the food to pass over. But I suspect that it was just a little bit of volume and he was feeling crappy as it is. So maybe it was that. I'm not 100% sure. I didn't do the history on this patient, so yeah. I think it would be considered stage 4. And then there was another question here. What's the full name of the cancer? So it was a clear cell carcinoma, but it's a renal cell carcinoma. So it's a cancer that originates from the kidney itself. All right. Any other questions? Yeah.
So earlier when you said that about the kidneys, we do a CT scan without contrast. Why couldn't we do an MRI?
So the MRIs are more expensive. They take a long time, and if we're looking at a bigger area, if there's any movement when the patient's doing an MRI, it can cause distortion of the image. And so the time, the cost, and the quality can be affected. And so MRIs typically aren't the best modality. You can probably get as much information from a CT than you can with an MRI. And then also, if you wanted to do an MRI with contrast, you'd run through the same issue where you can't really use the contrast because of the kidneys as well.
Oh, okay. Thank you.
Yeah, no problem. Any other questions? If not, if there is any other questions later on, feel free to message me or put it in the stream. Is an ultrasound also expensive and not needed as the first step type deal? So ultrasound is a lot cheaper actually. So a good first step would have been to get an ultrasound of the kidney if you're suspecting a kidney injury. So you can take a quick look at the ultrasound and you would probably see that mass there and then say that, yeah, there's something like cancer going on. You'd still have to correlate it with the GI bleed, but yeah, that's actually a good point. Ultrasound would have been a good step. It's pretty cheap. Any other questions? All right, I will let you guys go. If there's any more questions, feel free to message me, okay? Hope this was helpful.
Thank you. Have a good day.
No problem. Thanks guys.